Hi, and welcome to my presentation on neurofeedback as evidence-based treatment for attention deficit hyperactivity disorder. My name is Nathan Yankee. I'm a psychotherapist and neurofeedback provider in practice at Stone Creek Psychotherapy and Wellness Center, located in the Katy, West Houston area. For those of you seeking continuing education credit for viewing this presentation, a certificate for 1 hour of continuing education is available upon completion of an online quiz. The link to this quiz is listed in the video description below. Once completed and passed with a grade of 80%, a certificate will be sent within 24 hours to the email address provided. Stone Creek Psychotherapy and Wellness Center is a pre-approved continuing education provider in the state of Texas for licensed professional counselors and licensed clinical social workers. So I created this presentation because I perceived a need for more exposure to this information in our professional community. Just a little about me, I was introduced to neurofeedback in 2010 when I began practicing at Stone Creek. However, I was actually first introduced to biofeedback when I was a teenager by my own personal therapist who was working with me to help me resolve anxiety. Even then, I recall it was one of the more helpful things we did together, and I remember feeling better, and I actually stayed better. When I was in my graduate program, my university had a course in biofeedback listed in the catalog, but unfortunately the course was never offered. I think the faculty member offering the course had retired, and no one was available to teach the course. So when I arrived at Stone Creek, I remember thinking, neurofeedback, that sounds similar to biofeedback, and of course it was. Next I wondered, if this treatment's so great, why am I just now hearing about it? Why was it never once mentioned in graduate school or my early clinical training? I was intrigued, however, and sought out training in neurofeedback, and today I consider it to be a highly valuable addition to our practice. I won't lie, I get a little frustrated sometimes that neurofeedback isn't more utilized as a mental health intervention, or especially when I hear other professionals share misinformation about neurofeedback. Another part of me thinks, I get it. Unfortunately, most of us don't get any exposure to this treatment modality in our early training, and 10 years ago it was something I knew nothing about. So please know that no one will ever get any judgment from me for exposing a lack of knowledge on this subject. I continue to learn a lot about it myself, and I love talking to others about it. This presentation focuses on neurofeedback's application in ADHD. I intend to provide information about biofeedback and neurofeedback in general, what it is, and how it got started. I intend to provide information about the current level of research support relative to conventional treatment for ADHD. I also intend to provide information about when you might consider referring your client with ADHD for neurofeedback and when not. Neurofeedback has actually been practiced in the clinical setting as early as the 1960s. Pictured in the slide here are Elmer and Alice Green. The Greens were interested in studying the brainwaves of experienced meditators. Many of you watching are familiar with the Menninger Clinic, now located in Houston, Texas. The Menninger Clinic actually began in Topeka, Kansas, and it was here that Elmer and Alice Green piloted a successful clinical program in neurofeedback. They found that using neurofeedback, they could successfully train individuals to produce brainwave activity similar to that of experienced meditators. And they also found that this practice resulted in sustained clinical benefits. It's impressive to me that their team at Menninger were able to accomplish what they accomplished over 20 years before the so-called decade of the brain. Also impressive to me is that their methods for conducting neurofeedback are still in use today, although the technology has changed substantially, as we'll get into here in a little bit. So what is neurofeedback? Neurofeedback is a kind of biofeedback. It's biofeedback for the brain. And what is biofeedback? Before I get into that, I'd like to point out that virtually all of you who are viewing have done biofeedback. You just didn't know you were doing biofeedback. Have you ever stepped on a scale to measure your body weight with a health goal in mind? Have you ever taken your temperature to determine whether or not you had a fever, or to determine the severity of a fever? That's biofeedback. In biofeedback, a measure is taken of a physiological process that's occurring in the body. That measure is then provided to the person undergoing biofeedback, so that person can make use of the information. In neurofeedback, the physiological measure that's taken and provided or fed back to the client is a measure of their brain activity. Neurofeedback is concerned with the electroencephalogram, or EEG, which is informally referred to as brainwaves. The EEG provides information about the rate at which networks of brain cells are firing. You can think of brainwave frequencies as different speeds of brainwave activity, and problems are correlated with brainwave frequencies that are too high or too low in power, which is referred to as amplitude. For example, delta is the slowest of the frequencies we look at, between 1 and 3 cycles per second, and is associated with a deep sleep state. Someone who has high amplitude delta activity during the waking hours of the day might be presented with excessive fatigue or concentration difficulties. Someone who has low amplitude delta activity might have trouble getting restful sleep or might have difficulty soothing themselves. Theta, between 4 and 7 cycles per second, is associated with a drowsy, dreamlike state. Alpha, between 8 and 12 cycles per second, reflects an idling state in the brain and is associated with calmness. Sensory motor rhythm between 13 and 15 cycles per second is associated with a peak performance state of calm focus. Beta, between 16 to 24 cycles per second, is associated with active thinking, the type of brainwave frequency we expect individuals will produce when studying or problem solving. Fast beta, 25 cycles per second and faster, is associated with muscle tension and anxiety. In neurofeedback, a feedback loop exists, including the client, the clinician, and a computer interface. Small sensors are placed on the client's scalp, designed to measure brainwave activity. The signal from these sensors is processed through an EEG amplifier. The amplifier provides information to computer software, which is accessed by the clinician. The clinician has choices to make that determine the feedback presented to the client. So, for example, what frequencies does the clinician want the client to focus on? What level of challenge can the client tolerate? Based on the parameters set by the clinician, the client receives feedback when their brain moves in the desired direction that supports better functioning. The feedback can be thought of as a game. Different types of video games have been designed for this purpose, in which the client progresses in the game as the desired brainwave activity is achieved. The client may also watch a movie in which the goal is to keep the movie playing clearly on the screen. Another example would be the client reclining with eyes closed and listening to an auditory tone that increases in volume as the desired brainwave activity is achieved. In all cases, feedback is being provided to the client on their brain activity. An interesting thing about neurofeedback is that it doesn't appear to be volitional. In other words, the client does not have to try at it. I often use the following example to demonstrate this. If you were to go to most gyms or dance studios, you'd notice mirrors on the walls. Dancers or professional weightlifters, trainers, etc. train and practice often in front of mirrors. And as this is going on, They're making tiny adjustments to their form, balance, etc. They do so without thinking. It's happening naturally in the presence of the mirror. You can think of neurofeedback as a mirror for the brain. Although neurofeedback's clinical origins go back to about the 1960s, many mental health professionals remain unaware of it, and only a handful of universities in the US offer training in neurofeedback. Probably the biggest barrier to access to neurofeedback has been access to professional training and equipment. In the 1970s, only academic institutions could afford to purchase and train on the neurofeedback equipment, such as the equipment pictured below. The late 1980s brought the first neurofeedback available on a personal computer. During the 1990s, personal computers became far more widely accessible. Many developers of today's neurofeedback equipment got started around this time. Today, technological advances continue to push forth the availability and acceptance of neurofeedback. In this slide, you see a picture of our neurofeedback setup at Stone Creek. It's even become possible to receive neurofeedback through equipment connected to a smart device in the client's home, while a clinician runs the session in a remote location. Now, as promised, let's talk about ADHD. ADHD is probably the biggest application of neurofeedback. In the 1980s, a psychologist by the name of Joel Lubar was conducting research at the University of Tennessee. About a decade before, a researcher named Barry Sterman at UCLA had successfully trained cats to produce sensory motor rhythm through positive reinforcement. Sterman soon after began training humans to produce sensory motor rhythm, and found this to be helpful in reducing seizures. Joel Lubar became involved in replicating this research, and noticed that many individuals with epilepsy who benefited from the neurofeedback also experienced improvements in attention and reduction of hyperactivity behavior. Joel Lubar thereafter conducted numerous studies establishing the efficacy of neurofeedback for ADHD. In addition to establishing the efficacy for neurofeedback with ADHD, Joel Lubar identified brainwave signatures for ADHD. In general, he found that individuals with ADHD had higher amplitude slow brainwave activity, predominantly in the theta range, and predominantly in the central and frontal regions of the brain. He found that the ratio of slow to fast brainwave activity, the theta to beta ratio, was significantly higher in individuals diagnosed with ADHD. Inattention was associated with slow brainwave activity. Hyperactive and combined hyperactivity and inattentive presentations were also associated with slow brainwave activity with the addition of intermittent fast activity. Some amount of controversy exists over to what extent EEG signatures and other types of brain imaging should be considered in the diagnosis of mental health disorders, including ADHD. Our current systems of diagnosis rely on behavioral definitions for diagnosis of a mental health disorder, for example, the DSM and ICD. Assumptions are often made about what's occurring in the brain of someone who meets criteria for a specific diagnosis. In the case of ADHD, for example, if a physician prescribes a stimulant to your client based on symptom report measures, that physician has made the reasonable assumption your client probably has an ADHD brain, which is likely to benefit from a stimulant. This is standard practice. But in reality, no one really knows what's going on in your client's brain unless they've looked. In 2013, the FDA cleared the device pictured here, the Neuropsychiatric Electroencephalograph-Based ADHD Assessment Aid, or NEBA for short. This device is used by physicians as a diagnostic aid when ADHD is suspected and was developed based on Joel Lubar's work with the theta to beta ratio. I show this to demonstrate the level of recognition EEG has attained as a biomarker for ADHD. There's a term in use for some time now, personalized medicine, which comes to mind as I present this. As we know, not everyone with ADHD or any mental health disorder benefits from the same one-size-fits-all treatment. More and more, our clients and their providers will have access to this kind of information when making decisions about treatment, such as selecting medications, neurofeedback protocols, etc. The theta to beta ratio has demonstrated good predictive validity for whether or not a stimulant medication will be effective or produce side effects. In neurofeedback, we refer a lot to neurofeedback protocols. In simple terms, the protocol answers two questions: where and what. Where are the regions of the brain that are of interest to the clinician? This determines where we put the sensors. And what are we asking the regions of the brain to do differently? Clinicians are able to be quite creative with the protocols they design for use with their clients. Most neurofeedback software also allows clinicians to be quite creative in designing feedback suitable to their clients when their clients are successful in achieving the goals set forth in the protocol. For example, if the client enjoys contemplative practices such as meditation or mindfulness, neurofeedback might be done with eyes closed, and the reward might be the sound of crashing waves, seagulls, etc. If the client is a young child who enjoys competitive baseball, a sports game might be more appropriate. If the client is easily frustrated and has a low tolerance for difficulty, the feedback might be set to reward the client a higher percentage of the time. Neurofeedback is an art as well as a science, and it's very much in line with the philosophy of personalized medicine. Let's talk a bit about the standard of care for treatment of ADHD. The largest study of treatment effectiveness for ADHD ever has got to be the multimodal treatment study of children with attention deficit hyperactivity disorder, the MTA for short. This multi-site study with 600 children and funded by the National Institute of Mental Health began in the 90s and has had follow-up analysis at 2, 6, and 8 years post-completion. Participants were randomly assigned to receive medication management, multi-component behavior therapy, combined medication and behavior therapy, or usual community care, which meant just the local normative comparison group. After 14 weeks, it seemed that medication management and combined medication management and behavior therapy were superior treatments. However, at 2, 6, and 8 years, the different groups did not differ significantly on any outcome measure. Most discouragingly, the researchers report that, quote, the MTA participants fared worse than the local normative comparison group on 91% of the variables tested. These researchers conclude by stating that, quote, innovative treatment approaches targeting specific areas of adolescent impairment are needed, end quote. The authors also concluded there was no evidence to support, quote, long-term advantage of medication treatment beyond 2 years for the majority of children, end quote. Finally, the just published follow-up findings from the NIMH-funded Preschool Attention Deficit Hyperactivity Disorder Treatment Study, the PATS for short, found results virtually identical to those from the MTA study. These researchers report that, quote, medication status during follow-up on versus off did not predict symptom severity, end quote, and despite optimal parent training and systematic medication management at the study's outset, the authors concluded that, quote, ADHD in preschoolers is a relatively stable diagnosis over a 6-year period. The course is generally chronic with high symptom severity, and impairment in very young children with moderate to severe ADHD, despite treatment with medication. Development of more effective ADHD intervention strategies is needed for this age group." End quote. So this is the current standard of treatment for ADHD. I think it leaves something to be desired. However, for most insurance carriers, these are the only reimbursable treatments for attention deficit disorder, medication and behavior therapy. The Association for Applied Psychophysiology and Biofeedback's 2016 review of evidence-based practices in biofeedback and neurofeedback concluded that neurofeedback for the treatment of ADHD meets standards for the highest level of treatment efficacy, level 5, based on criteria set forth by the American Psychological Association. Let's review the 5 different levels to get a sense of what this means. First, there's level 1. Level 1 is considered not empirically supported. Treatments in this category are supported only by anecdotal reports and are case studies in non-peer-reviewed journals. Level 2 is considered possibly efficacious. Treatments at this level have at least one supporting study of sufficient statistical power with well-identified outcome measures, but lacking randomized assignment to a control condition internal to the study. Level 3 is considered probably efficacious. Treatments at this level have multiple observational studies, clinical studies, waitlist controlled studies, and within subject and intra-subject replication studies that demonstrate efficacy. Level 4 is considered efficacious. Here's the description of treatments at this level. 1. In a comparison group with a no treatment control group, alternative treatment group, or sham placebo control utilizing randomized assignment, that investigational treatment is shown to be statistically significantly superior to the control condition, or the investigational treatment is equivalent to a treatment of established efficacy in a study with sufficient power to detect moderate differences. And 2, the studies have been conducted with a population treated for a specific problem, with whom inclusion criteria are delineated in a reliable, operationally defined manner. And 3, the study used valid and clearly specified outcome measures related to the problem being treated. And 4, the data are subjected to appropriate data analysis. And 5, the diagnostic and treatment variables and procedures are clearly defined in a manner that permits replication of the study by independent researchers. And 6, the superiority or equivalence of the investigational treatment has been shown in at least 2 independent research settings. Level 5, the highest level of treatment support, is considered efficacious and specific. Here's the description. Evidence for level 5 efficacy meets all of the criteria for level 4. In addition, the investigational treatment has been shown to be statistically superior to credible sham therapy, pill, or alternative bona fide treatment in at least 2 independent research settings. One of the most common criticisms I've heard about neurofeedback from clients and professionals alike is that it's susceptible to a placebo effect. The term sham, just mentioned, is referring to sham neurofeedback, feedback that's not based on the client's brain activity, where the rewards in the game are presented randomly. Participants in these studies do not know whether they are receiving neurofeedback or not. So in essence, the placebo effect has been controlled for, and significant differences have been noted between the groups. The first study I'd like to focus on is a 2006 study by Beauregard and Levac. The study participants were a group of unmedicated children diagnosed with ADHD. The children were given a battery of neuropsychological tests. Only those with full-scale IQs above 85 were included in the experiments. Those with comorbid axis 1 disorders, comorbid learning disorders, or neurologic disorders were excluded from the study. Half of the group were randomly assigned to the experimental group, and half were assigned to the control group. You can see in this slide that there were no significant differences between the groups to be compared on any of these neuropsychological measures in the baseline testing. In addition to baseline neuropsychological testing that was repeated at the end of neurofeedback, both groups completed fMRI brain imaging at the beginning and end of the experiment. fMRI stands for Functional Magnetic Resonance Imaging. The functional part refers to tasks that are administered during the imaging designed to activate different regions of the brain. In one task, the counting Stroop task, participants were asked to name the quantity of numbers pictured as they appear on the screen. This task measures participants' abilities to inhibit a well-learned impulse. The second task, the Go, No-Go task, asks participants to respond by clicking a clicker when only when a target stimulus appears on the screen. This task measures participants' abilities to inhibit impulses and respond appropriately to stimuli. The neurofeedback was based on protocols originally developed by Joel Lubar. It was conducted over a period of 13.5 weeks, 40 sessions with 3 training sessions per week. The training was divided in 2 phases. In the first phase, subjects were trained to enhance the amplitude of sensory motor rhythm and decrease the amplitude of theta. In the second phase, subjects learned to inhibit their amplitude of their theta waves and increase the amplitude of their beta waves. And here are the results. Children not receiving neurofeedback did not evidence any significant changes in brain activity during the Stroop task and pre- and post fMRI imaging. Children completing neurofeedback evidenced significant changes in activation of the right dorsal division of the anterior cingulate cortex, associated with mental flexibility, the left caudate nucleus, associated with goal-directed behavior, and the left substantia nigra, seat of the neurotransmitter dopamine, often found to be dysregulated in ADHD. These differences are shown in the bottom right corner of the slide. On the Go, No-Go task, children not receiving neurofeedback again did not evidence any significant changes in pre- and post fMRI imaging. Children completing neurofeedback evidenced significant changes in activation of the right dorsal division of the anterior cingulate cortex, the left caudate nucleus, the left substantia nigra, the left thalamus, considered to be the brain's brain, and pacemaker for the cerebral cortex, and the right ventrolateral prefrontal cortex, associated with inhibition and selection of appropriate responses. The big take-home from this study, in my opinion, is the finding that neurofeedback appears to facilitate neurological changes that are consistent with improvements in ADHD symptoms. Let's review a second study. This is a 2013 study by Victoria Miesel and colleagues, published in the journal Biological Psychology. The study involved children aged 7 to 14 years determined to have ADHD through a semi-structured clinical interview. Children with comorbid disorders other than oppositional defiant disorder were excluded from the study. Also excluded were children with full-scale IQs below 80. Children were not receiving medication for 2 weeks prior to beginning treatment or co-occurring psychotherapy. Children were randomly assigned either to the group receiving medication or to the group receiving neurofeedback. The medication group received daily methylphenidate. The neurofeedback group received 40 sessions of neurofeedback to reduce the theta to beta ratio. Here are the results post-follow-up. Both the neurofeedback group and the medication group evidenced significant changes in ADHD symptoms. Cohen's d is a measure of effect size. Values of 0.2 are considered a small effect size, 0.5 is considered a medium effect size, and 0.8 is considered a large effect size. The most significant improvements for the neurofeedback group were found for inattention symptoms as rated by mothers. No significant differences in improvements were found between the medication group and the neurofeedback group. In my opinion, the take-home message from the Mizell study is that neurofeedback appears to reduce ADHD symptoms in a manner similar to that of psychostimulant ADHD medication. The third study I'd like to review is a 2009 study by Olga Gvinzelbin and colleagues, published in the Journal of Child Psychology and Psychiatry. 102 children with ADHD between the ages of 8 and 12 were randomly assigned to one of two groups. One group received neurofeedback, and the other group received attention skills training via an award-winning computerized attention skills training program called Skillies. Two samples of children evidenced no significant differences in full-scale IQ or other measures of symptomatology. The children assigned to the neurofeedback group completed 26 sessions of neurofeedback, again, involving neurofeedback protocols aimed at reducing the theta to beta ratio. Parents were not told about the treatment conditions of their child. For both neurofeedback and the group receiving computerized attention skills training, parents and child participants were told only that they were completing experimental but promising treatment modules for ADHD. Children trained in pairs, but children from different treatment groups were not paired together. Great care was taken to control the effects of bias in parents' reporting. Additionally, parents completed what were referred to as parental evaluation placebo scales, and the researchers shared this data in the study. There was no significant difference between the groups in parents' attitude towards the treatment or how parents rated the motivation of their children. For example, parents were asked to rate the item, "My child does not like the training." 42% of the parents in the neurofeedback group and 37% of the parents in the control group could not reliably quote treatment assignment of their child. In other words, these parents voted, "I don't know which training my child attends," or "My child attends a combination of neurofeedback and attention skills training," or the parents just estimated the wrong group. Now the results. Parent and teacher ratings are summarized in this table. The FBB-HKS is an ADHD rating scale and the primary outcome measure. Improvement of the neurofeedback group on the total score was superior compared to the attention skills training group. This effect reached a medium effect size of 0.6. In both groups, a significant improvement resulted. On the subscale level, improvements in attention and hyperactivity and impulsivity of about 25 to 30% in the neurofeedback group were significantly larger compared to about 10% in the attention skills training group. Referring to oppositional and conduct behavior, the reductions in both the FBB-SSV subscales and the neurofeedback group exceeded the changes in the attention skills training group. The FBB-SSV refers to a general symptom rating scale. For the SDQ, Strengths and Difficulties questionnaire, total score as well as for the hyperactivity subscale, the decrease in the neurofeedback group was significantly larger than in the attention skills training group. Concerning problematic behavior in family situations and homework problems, both groups did not differ significantly from each other. Post hoc t-tests conducted for the two groups separately indicated improvements in the neurofeedback group as well as the attention skills training group. These were the parents' ratings. Now let's look at the teachers' ratings. For the ADHD rating scale total score, the reduction in the neurofeedback group was superior to the effect in the attention skills training group. A significant effect was also found for the inattention subscale and a trend for the hyperactivity impulsivity scale. Effect sizes of 0.4 to 0.64 were in the same ranges for the parent ratings. For me, the major take-home from the Gevinselben study is that neurofeedback appears to be more effective than a credible attention skills training program in improving ADHD symptoms. A follow-up study by Sahan Ghani and colleagues looked at maintenance of results of the neurofeedback group at 6 months and 2 years after the last training session. At both of these follow-up points, you can see that improvements as measured on behavior rating scales have been maintained. The review also looked at changes in the theta to beta ratio. You can see, also, that significant changes in brain activity occurred and were maintained at 6 months and 2 years. So another important take-home from the research begun by Gevinselben and colleagues is that the effects of neurofeedback tend to endure beyond 2 years after treatment. In 2018, the American Academy of Pediatrics conducted their own independent review of 54 studies of non-pharmacologic treatments, including neurofeedback, cognitive training, cognitive behavior therapy, child-or-parent training, dietary omega fatty acid supplementation, and herbal and/or dietary approaches. They determined that neurofeedback can be considered a level 1 best support intervention for attention deficit and hyperactivity behaviors, along with behavior therapy and medication, parent management training, and self-verbalization. For reference, other treatments reviewed were contingency management, education, parent management training with problem solving or with teacher psychoeducation, physical exercise with or without relaxation, social skills and medication, working memory training, parent management training and social skills, relaxation, self-verbalization and contingency management, social skills, attention training, client-centered therapy, CBT, CBT and anger control, CBT and medication, family therapy, parent coping/stress management, parent management training and self-verbalization, problem solving, psychoeducation, self-control training, self-verbalization and medication, and skill development. So, the proliferation of supportive research findings has led to increased support of neurofeedback for the treatment of ADHD by the mainstream medical community. Remember how I discussed earlier about the importance of personalized medicine and mental health treatment? That more and more our field is including neurological biomarkers to fine-tune treatment selection for individuals meeting behavioral criteria for mental disorders? I want you to bear in mind that this was not the approach taken with the participants in any of the studies we just reviewed, although each demonstrated successful clinical outcomes in treating ADHD with neurofeedback. In each of these studies, participants were selected based on whether or not they met criteria for ADHD based on DSM criteria. If assigned to the experimental group, a standard protocol was applied. The reason I'm bringing this up is that it's highly likely that neurofeedback in clinical practice achieves even higher success rates for individuals diagnosed with ADHD than what has been observed in these studies. The International Society for Neuroregulation and Research, or ISNR, sets guidelines that most neurofeedback providers abide by. One of these guidelines is that providers, quote, plan and carry out an organized course of neurofeedback that is based on an initial assessment that is adequate for the presenting problem and goal, including a pre-training EEG assessment, end quote. In other words, generally, when individuals diagnosed with ADHD are referred for neurofeedback, they will not simply receive neurofeedback based on a standard ADHD neurofeedback protocol. The diagnosis will be considered along with an assessment of their individual brain activity in choosing the protocol. Personally, I think of diagnosis as a kind of shorthand. It's information about how an individual is presenting behaviorally. A supervisor once told me something that stuck. That diagnosis is a map but it's not the terrain. I invite you to think about the many ways our bodies might behave when we're sick. For example, we have a fever. There are many potential underlying disorders or illnesses that might cause a fever. Some are benign and some are actually life-threatening. A physician would never stop their process of diagnostic inquiry at this point and diagnose something like fever disorder. The idea of such a thing is ridiculous, yet in our field of mental health, we're not so distant from this way of thinking. Neurofeedback is one mental health treatment in which the actual organ of interest, the brain, is assessed. A pre-training EEG assessment can be a number of different things. At minimum, it can involve taking a recording of EEG brainwave activity in a single brain region. More ideally, several brain regions would be observed and compared against a clinical database to assess how closely the individual matches samples of EEGs of individuals with a variety of clinical disorders. At maximum, the individual would have what's called a full QEEG brain mapping, where 19 channels or more of EEG brainwave activity are recorded simultaneously and compared against age-matched norms. It's very possible that many of the clients we see in clinical practice would not meet inclusion criteria for any of the studies just mentioned. Each of the studies excluded individuals meeting criteria for mental disorders other than ADHD, with maybe the exception of oppositional defiant disorder. Diagnosis of any mental health disorder raises the likelihood that one meets criteria for another. With ADHD, comorbidity is the rule, not the exception. In a study of 2,447 children and adolescents aged 5 to 17 years with one or more psychiatric disorders, 27% were diagnosed only with ADHD and 16% only with another psychiatric disorder, while 57% had two psychiatric disorders and 66% of these also had ADHD. So this is a pretty heterogeneous group and a pretty complex group where symptomatology is concerned. The beauty of neurofeedback is that these comorbidities can be addressed succinctly by focusing on the behavioral source in the brain. When you consider the evidence of success for neurofeedback in treating ADHD, along with the ability to design treatment protocols specific to the client's EEG, it's a pretty powerful intervention. So like any treatment, neurofeedback has limitations, and while highly adaptable, is not efficacious for everything, everyone, or every situation. Let's talk about some of the considerations for treating clients with neurofeedback. Although it seems to me that more and more people are hearing about neurofeedback, in general, I found this is usually not the first thing that people try when attempting to address their ADHD or other mental health problem. Often it seems like people have tried anything and everything under the sun before discovering and attempting neurofeedback. In the case of children with ADHD, parents are desperate for anything that will relieve the symptoms their children, and by extension their families, are experiencing. These tend to be the cases with lots of complex comorbidity, complex family systems dynamics, complex medical histories, complex trauma histories, etc. On the surface, observing their desperation to make something happen, it may seem that these would be ideal candidates for neurofeedback, and many do go on to complete a course of neurofeedback with successful results. Folks in desperation often, at least in the beginning, present an attitude of compliance. Too often, however, in my experience, neurofeedback can fail miserably for these clients. So I want to discuss with you a few factors that should be considered. One of the things I'm most aware of when meeting with prospective adult neurofeedback clients or parents of prospective child neurofeedback clients is the level of curiosity they approach the treatment with. For example, it's pretty understandable that parents of ADHD children are going to expect some reduction of their children's ADHD symptoms. I tell these parents that we're going to start the neurofeedback with an assessment of EEG brainwave activity, that the assessment is going to help us discover what in their child's brain is underlying the ADHD symptoms. Most parents are curious to learn about how their kids' brains work. They express this interest by asking questions. When parents ask no questions in this situation, when there's no curiosity about what's underneath the impulsivity, inattention, hyperactivity, etc., that, in my experience, is unusual, and it's a bit of a red flag. This is one of the ways I believe that neurofeedback, while different from psychotherapy, shares something in common. Both psychotherapy and neurofeedback aim to address the client's awareness of dynamics underlying their current behavior. Some of the medicalized imagery associated with neurofeedback, electrodes applied to one's head, EEG amplifiers, equipment, etc., might contribute to the sense that something is going to be done to the client's brain, similar to how things are done to one's physiology in medical treatments. This is not the case. Neurofeedback is not an invasive procedure in this way. We are simply holding up a mirror to the client's brain and allowing it an opportunity to become more aware of itself. Many times, the same as with talk therapy, a new awareness also comes with new responsibility to make changes in one's life. This is where access to talk therapy can be highly valuable, if not necessary, during neurofeedback. Like therapy, folks who come in simply expecting to be fixed are going to have a difficult experience. On a more practical level, clients need to have the financial and time resources required for neurofeedback to be successful. Neurofeedback is a structured and time-limited modality. In general, people need to be able to commit to at least 20 sessions at a frequency of at least 2 sessions per week for the neurofeedback to be effective and for the effects to persist. Gaps in treatment due to frequent cancellations, unreliable transportation, running out of funds, no-shows, home equipment not being charged at the time of the session, etc., are likely to result in unsuccessful treatment outcomes. Clients who are in active crisis, who likely will leave neurofeedback shortly after starting inpatient hospitalization, who are on waiting lists for residential treatment facilities, may not be available to complete neurofeedback treatment once they've started, if they've started. Many of these clients will be able to resume neurofeedback once the necessary stabilization has taken place. Another important consideration is that of secondary gain. Secondary gain refers to the idea that a person experiencing symptoms has a motivation to remain symptomatic because they're receiving some benefit. There was a time when the thought of secondary gains for me brought up thoughts about malingering, a situation where a person consciously feigns symptoms to achieve some benefit like disability benefits. These situations are rare. In this case, I'm speaking more to secondary gains which aren't usually in the realm of conscious awareness for most people. For those of you who have provided services in medical settings, hospitals or pain management clinics, for example, this consideration is probably more on your radar. Because of the medicalized imagery associated with neurofeedback, I think it needs to be on our radars too. Here's a familiar scenario to help demonstrate what I mean. An adolescent male, we'll call him John, is referred for neurofeedback to treat his diagnosed attention deficit hyperactivity disorder, predominantly inattentive presentation. He's just begun his junior year of high school. He's been tried on multiple stimulant and non-stimulant medications with minimal benefit. John's parents have also hired an executive skills coach, but the skills just haven't seemed to transfer. He gets accommodations in school, but he continues to underperform academically. Academic underperformance, to his family, means he's earning mostly B's and an occasional C in advanced placement classes. Everyone's very aware of the ADHD diagnosis and appears comfortable talking about it. The initial assessment of his EEG is interesting. He has lots of theta activity in frontal brain regions, which is a marker for ADHD. However, and more significantly, he has excessive beta activity in the right frontal cortex relative to the left, associated with depression. His alpha also appears to be under-responsive to his eyes closing and opening, a finding commonly seen in emotional trauma. Because the initial referral was for ADHD, sessions are begun aimed at reducing the elevated theta amplitudes in the frontal cortex. 7 sessions in, the client is not experiencing any changes in behavior. The parents are disappointed, and the client, if anything, seems to be withdrawing and his grades are slipping. John attributes this to his broken, messed up ADHD brain. What could be happening here? Let's suppose we explore the other findings in the EEG associated with depression and emotional trauma. Let's suppose John reveals that he spends significant time alone. His parents haven't ever prioritized his social development or their own, for that matter. They don't have friends of their own, really. They haven't encouraged him to have friends of his own, or supported him in finding out how. He's polite as far as adults are concerned, but has no friends to speak of, and he defensively expresses his belief that his same-aged peers are not worth any of his time, and they're immature. He's avoided homecoming dances the last 2 years and has no desire to go this year. He dropped out of band his freshman year. Neither he nor his parents brought up social development as a concern. They're okay with him dropping band, as it allows for more time for him to focus on school. Let's think about what might be happening for this young man. College away from home is on the agenda in the next 2 years, and everyone around him is talking about life after high school, relationships, the world of work, etc. John has no experience of himself having the skills or social comfort necessary for success in adulthood. The narrative of his broken, messed up ADHD brain provides an answer to the question as to why he is not progressing towards a successful adulthood. It does so in a way that allows him to avoid what he is most afraid of, which is social rejection and/or failure. It also does so in a way that allows his parents to continue focusing on what they're comfortable focusing on, while avoiding areas they're less comfortable with. This is the secondary gain I'm referring to. Now let's suppose we were able to confront this issue with the parents in a way they were able to hear it. Let's suppose we were able to partner with John's parents to create opportunities for their son's social development, and John participated while we worked on regulating brain circuitry underlying symptoms of depression and dissociation, which had been manifesting as inattention and exacerbating the problem of ADHD. That would be a pretty powerful intervention. It's the sort of treatment that would need to happen for a client like this to be successful. So, in summary, The ideal neurofeedback candidates are curious and open as to the possible roles of their brains in the behaviors and symptoms they present with. They have the appropriate clinical support available in the right quantity. Their family system has the appropriate clinical support available in the right quantity. Really, the most important considerations are a desire to change and having the financial and time resources to commit to neurofeedback. The rest can be accomplished with the right clinical and social support in the right amount at the right time. That wraps up my presentation on neurofeedback as evidence-based treatment for attention deficit hyperactivity disorder. Thank you for joining me, and I hope this information enhances your clinical work. Take care.